and a visiting professor in the Center for AIDS Prevention Studies at the University of California, San Francisco. Dr. Howell's research focuses on reducing racial inequalities in HIV incidence through community-engaged applied communication science. She develops, implements, and evaluates theoretically grounded communication interventions focused on impacting individual and social structural barriers to HIV prevention. Now, this research is informed by and developed in close collaboration with community partners. Her research has been funded through various organizations, such as the MCA AIDS Fund and government agencies like NIH and CDC. Dr. Howell's work has appeared, I know, that in top communication, health psychology, and public health journals. So I'm just gonna, maybe throw in a few personal notes that, I've been following Dr. Howell's research over the years, especially impressed by her work on health disparities. And I just feel like, especially in the field of communication, we have very few scholars who have devoted their career to tackle this really thorny issue in communication and public health in general. So I think we're here today to really listen to one of the leading scholars in health disparity and communication. And the title for her presentation today is Masks Are the New Condoms, Health Communication, Intersectionality, and Racial Equality in COVID Times. And I'm very pleased to let you know that this work Dr. Howell's going to present, and maybe part of it, has also been published in a recent special issue on COVID public health communication in the Journal of Health Communication, which I had the pleasure of editing. So it was a great pleasure working with Dr. Howell on this article. So I'm really looking forward to hearing more about it and your recent thoughts about health inequality and COVID. So I'm gonna hand it over to Dr. Howell. Is presentation mode enabled, Yuan?
Yes.
Okay. So go ahead, Shawnika, the stage is all yours. I just want to remind everyone during the talk, please let's all mute our mic, and we'll have about 10 to 15 minutes at the end for audience members to ask questions. And you can always put in your questions in the chat, and then we will help you ask those questions to Dr. Howell when the time comes.
Thank you. Is my mic on? Yes. Okay. Right. So we're talking about masks are the new condoms. Thank you for the invitation to talk today. I'm very excited, and I'm really looking forward to the discussion portion of of this presentation. And I very much look forward to hearing your thoughts about some of these pieces I'm going to pepper throughout. There is much in common between the COVID and HIV epidemics, and much we can learn from the HIV epidemics to stem the inequities that have already started to emerge in terms of COVID. Today, I want to focus on one particular lesson that we've learned to think about how we communication scholars might think about inequities in COVID outcomes. And in doing so, I aim to bring our attention to some of the ways that we can develop communication interventions that deal with the fundamental causes of these inequities and so many more. Health communication scientists and practitioners increasingly acknowledge that health disparities are driven by social and structural factors. That is, these fundamental causes lie largely outside of the control of the individual who's experiencing the inequities. They magnify risk, they create barriers to prevention, they create barriers to treatment and medication adherence. And these sort of these social and structural barriers result in inequities in disease burden. What I'm offering here for your review, give me just one second. There we go. This figure represents inequities in HIV diagnoses by race. And I just want to point out here that these tend to these inequities in HIV and other health outcomes tend to systematically disfavor Indigenous communities, communities of color, as well as the poor, sexual minorities, those with disabilities, and other marginalized groups. In the case of HIV, a long history of systemic racism has created circumstances in which communities of color experience disproportionately high HIV risk, incidence, and mortality. What this figure is showing you is that the Black community represents 12, 13, 14% of the population, but we represent the majority of new individuals with new HIV infections. And because these disparities are born out of social and structural causes, as new treatment and prevention options emerge, they will diffuse inequitably. And as you can see here, this is the distribution of pre-exposure prophylaxis uptake. PrEP, or pre-exposure prophylaxis, is a daily pill that can be taken to prevent HIV. It is highly, highly effective. But what you can see is that the populations that are most impacted by HIV incidence are not the populations that are using PrEP. In other words, there's a demonstrable need that's not being met by the diffusion of this biomedical prevention tool. PrEP can be delivered in a pill form. It can be delivered now using long-acting medication, but the different formulations continue to diffuse inequitably. The same can be said for COVID. The distribution of COVID mortality and morbidity is inequitable. The share of cases and the share of deaths that would be expected based on the share of the population far exceeds the share that would be expected in the population. So for example, the Black community is 14% of the United States. We should represent 14% of COVID infections. We should represent 14% of COVID deaths under conditions of equity. But what you can see is that communities of color are experiencing dramatically more COVID infections and poorer health outcomes in relation to COVID. So I'm thinking about, okay, how can we, as communication scholars, think about inequities that point in ways that point to viable paths for communication solutions? Intersectionality is an essential framework for understanding and addressing health inequities. Intersectionality attends to the ways that institutional and social forces interact, they interlock, like racism, classism, sexism, ableism. They interlock and they interact with individual identity dimensions to afford privilege and disadvantage differently for people at different social locations. Power is central to intersectionality. It's not just about slicing dicing the data into smaller and smaller and smaller identity categories. It's about understanding and identifying how power works to shape privilege and disadvantage for people at different social locations. This intentional focus shifts the onus of responsibility for change from the individual whose opportunities are constrained to the system that is constraining the opportunities and magnifying the risk. So intersectionality prescribes a means for thinking about and understanding and identifying the ways that disparate COVID outcomes are magnified by social and structural discrimination. I'm going to offer you just an example. So when we think about COVID inequities in ways that center power, we're arguing that sexism, classism, xenophobia, and particularly racism interlock to shape inequitable COVID risk, prevention, treatment, and recovery outcomes. And there are innumerable mechanisms at work, right? This is complex. I'm highlighting just a few of them for you here. So for example, classism, sexism, xenophobia, racism, they interlock to shape the quality of healthcare that people receive, which in turn shapes risk prevention and recovery outcomes. We could focus our attention, for example, on the ways these factors interlock, these isms jointly affect labor practices and policies, where people live, how free people are. And we could focus our attention anywhere on this conceptual model. In communication scholarship, we tend to focus our attention on individual responses to risk exposures. right? We think about prevention, we think about treatment. We could, however, focus our attention on the fundamental causes of these inequities. And in doing so, we could address multiple pathways by which the inequities emerge. In other words, addressing COVID risk exposures, for example, we can make headway on that. We have quality theories, we have highly trained individuals out there doing the work on the ground. We can make headway on those outcomes, but in the long term, what we won't be doing is making headway on the inequities. Because if you solve a problem at the risk exposure level, all you're doing is putting a Band-Aid over the actual problem. It's like playing whack-a-mole, because you solve this problem, but you haven't actually dealt with the fundamental cause of the problem. And so new pathways will emerge when we solve others. And so I argue that we could be focusing our attention on the fundamental causes and thereby impacting multiple pathways simultaneously and reducing inequities proper. This is an important lesson that we should learn from the HIV epidemic. When we focus at the individual level, we can make headway, we can reduce transmissions, but what we don't do so well is at eliminating inequities, because we aren't dealing with the problems that cause the inequities in the first place. In order to address inequities, we have to address fundamental causes. I'm not saying that individual protective behaviors are not important. Masks are important. Vaccination is important. Condoms are important, but face masks and social distancing are not going to be effective at ameliorating racial disparities in COVID outcomes. We know from HIV that the same exact health behaviors offer different levels of protection depending on the social and structural and contextual factors that shape and constrain prevention, risk, and recovery. A good example of this is condom use. We know, for example, that the same risk behaviors in using a condom in Washington, D.C. is very different than using a condom in Madison, Wisconsin, right? Because if that condom breaks in Washington, D.C., the risk exposure is much higher relative to Madison, Wisconsin, purely because of the HIV prevalence in the community. There's just more HIV out there, and people are more likely to come across it in a context of high prevalence. So in that sense, the same exact prevention behavior is not conferring the same amount of protection in different geographical locations. And that has everything to do with community prevalence. We focus a disproportionate amount of our scholarly attention, I would argue, on individual level risk factors, yet we communication scholars are uniquely prepared to deal with these fundamental causes. We know this from HIV. We've seen it play out again in COVID. Unless we address the fundamental causes of inequities, they will continue to show up. And this is why I propose that masks are the new condoms. As racism and its intersecting cousins like heterosexism and classism and sexism, they're all social phenomena that are constructed and transmitted through communication. So it is within the purview of communication scholarship and practice to lead the efforts to mitigate racial bias as a means to bring about health equity. But racism is deeply woven into the social fabric. And so our efforts to interrupt systemic racism must include strategic communication efforts that are developed through an intersectional lens and that work at multiple levels of the social system if we are going to be effective at addressing fundamental causes. Today, I want to talk to you a little bit about my scholarship, and I have focused my career on interrupting health inequities using strategic communication efforts that are developed through an intersectional lens and that work at multiple levels in the social system. I won't go through all of these studies here today, but I just want to show you, for example, and particularly graduate students, the possibilities for working at multiple levels of intervention. In 2008, there was a 144% increase in HIV infections in Milwaukee County. So CDC sent some folks out to do an investigation to try to understand what's the cause of this hotspot, what's going on here. So they did a series of in-depth interviews. This figure represents the results of these in-depth interviews. These are the pathways through which homophobia, which is a fundamental cause of HIV infection, impacts individual HIV risk and infection. So I'll just walk you through a couple of pieces of this conceptual model. From this perspective, Homophobia leads to housing instability. So a young man comes home, tells his family that he's gay, or he's bisexual, or he's having sex with men. And in response, his family puts him out of the house. This young man now needs to find a place to live, needs to find food, needs to find basic necessities, right? And how is this young man going to find those things with relatively little preparation? Typically what happens is you would find housing and support from someone who's more senior, right? Someone who's got resources to share. And among men who have sex with men, the prevalence of HIV is around, the estimate is that 1 in 2 men who have sex with men in Milwaukee who are men of color will be diagnosed with HIV in their lifetimes. So we have a young man who needs food, shelter, housing. We have an older man, has resources, has funds, can help support this young man, who says, yeah, I got a place. You can come and stay here. The person who is in need of support has low power in this situation, low power to negotiate condom use, low power to negotiate sex. And so by virtue of being put out of the home, this person's HIV risk has increased just by virtue of the fact that his power is constrained and he's relying on someone else for basic necessities. Homophobia leads to HIV stigma, which leads to a lack of HIV disclosure to partners, which in turn heightens HIV risk. Homophobia leads to school-based sex education that doesn't actually deal with same-sex behavior in any reasonable kind of way, which leads to a lack of knowledge about HIV risk exposure, which heightens HIV risk. Homophobia also leads to internalized homophobia for some. And for some, the coping mechanisms for that internalized homophobia include alcohol, substance use, and so on. And we know that when you pair substance use and alcohol with sex, the likelihood of protection goes way down. So through that pathway, homophobia also magnifies HIV risk for young men. I say all of this to say that we could deal with each of these maladaptive responses. But if we're successful in dealing with that response, it's like digging in the sand. We'll dig a hole, we'll pull out that response, and then immediately the sand starts filling back in because we haven't actually dealt with the fundamental cause of the problem. So another mechanism will emerge in its place unless and until we deal with the fundamental causes. So together with Diverse and Resilient, a community-based organization out of Milwaukee, we developed the Acceptance Journeys campaign to address homophobia in Milwaukee in the Black community. The Acceptance Journeys campaign came out of a series of discussions, which led us to conduct a community readiness assessment so that we could understand where the community was and its readiness to address the problem of homophobia. And based on that community readiness assessment, we learned that the community was at very low levels of readiness, meaning people weren't very aware of the problem and were very resistant to intervention on this topic. And under those circumstances, the recommendations from the readiness, the sort of readiness toolkit, is to engage in low, subtle intervention, community conversations, interpersonal persuasion, the use of narrative, and so on. And so we took those recommendations and we built around them. So now we have a sense of how we want to deliver the intervention, but we didn't know what to say. We didn't know how to say it. We didn't know where we should put it. So we conducted a series of focus group discussions to develop the messages, to identify the core of our messages. And then we concept tested those messages with samples from the population in Milwaukee. Then we launched those messages. And after about 6 or 7 months, we launched a survey in order to evaluate their effectiveness. This is a process that we repeated every year for 5 years. And the result of that process was the Acceptance Journeys campaign. But before I get into the meat and potatoes of the campaign, I just want to talk a little bit about the formative work that led us to make the decisions that we made. Through our message design focus groups, we interviewed 8 to 10 Black adults. We wanted to interview people who have power, people who have resources. That is, people who could affect the life outcomes of young gay men, their families, their friends, their neighbors, and so on. We wanted to identify positive themes that we could highlight through our messaging and interactions and perceptions. We wanted to identify negative beliefs or beliefs in incorrect information so that we could decide whether we wanted to try to correct the information or offer alternative formulations of the belief that are more favorable, or maybe we should just steer clear of it altogether, because if we don't think we can be effective at changing a particular belief that is harmful, in trying to change it, we would be priming the population. And so we could generate backlash or boomerang kinds of effects. So we wanted to identify what we should also be steering clear of. From those discussions, we arrived at a series of themes that we thought would be fruitful to address through a persuasive campaign. For example, come as you are the church came up over and over and over and over in both positive and destructive ways. For instance, come as you are, the church accepts everyone, unconditional love of family and friends and community. These are themes that we can underscore. These are things that we can highlight through persuasive messaging. And as with civil rights and discrimination, that is, we know what it is like to be discriminated against. We know what marginalization feels like and what it does to our communities. How could we do this to our own? And that came up over and over and over. Negative themes included boundaries. Excuse me, I have a disclaimer. I'm going to offer some paraphrasing of what was said in the focus groups. You may choose to mute me at this time, and I will give you a signal when it's safe to come back. But also I feel the need to articulate, these are not my beliefs. Okay, so I'll signal when it's safe. Okay, boundaries. People talked a lot about concern for their children and feeling as though gay men will, that one needs to put boundaries over the spaces and places in which gay men can occupy in order to protect children, in order to protect siblings, and so on. People also talked about gay men as being an affront to masculinity. They would say things like, God made Adam and Eve, not Adam and Steve. They would say things that, such as, oh, he's not a real man. And they would say things about contagion or how people become gay. And so we thought these are things that perhaps we can address through persuasive messaging in varying levels of subtlety. And now it's safe to come back. And so based on these themes, we identified a series of recommendations. First, we should harness the power of narrative. Narrative allows us to fly under the persuasive radar so that as we're offering our persuasive messaging, we can avoid people putting up their cognitive defenses if we tell personal stories. It's hard to counter-argue with a personal story. That in terms of exemplification, it's also hard to counter-argue with a narrative that you're immersed in. If you're paying attention to the story and you're drawn into it, and it's a role model talking about their life experience, it's very difficult to counter-argue that successfully. Prejudice theorizing argues that discrimination sits on a table and the legs are stereotypes. And our thinking was, and that what I mean by that is that prejudice relies on the assumption of outgroup homogeneity. They are more like each other than we are like them. And so we're not like them, but they're like each other. They're similar in some respect, and that's typically some derogatory respect. And so our thinking was that if we could undermine some of those stereotypes, we could sort of knock the legs out from underneath prejudice and discrimination. If we could sort of combat these perceptions of gay men all being feminine in their presentation, for example. Social cognitive theory, we leaned on social cognitive theory's observational learning tenet and sort of tied that together with exemplification in anticipation that hyper-local role models, seeing your neighbors and your friends talking about their own stories, talking about their own journeys to acceptance, can be rather persuasive. And then we relied, in terms of thinking of our outcome, we relied on a stages of change perspective, such that homophobia and acceptance is not a dichotomy. There's a lot in between, and people can take incremental steps toward acceptance. It's not you're either a homophobe or you're not. So we relied on the community promise model to tie all these various pieces together. The community promise model uses transitional characters, role model stories. It's designed to be hyper local and focus on positive reinforcement rather than finger wagging. And it offers an opportunity for rehearsal. And so in our messages, we decided to address religion on its own terms. That is, highlight acceptance and unconditional love. And the language of acceptance journeys is borrowed from the church. It's borrowed from the concept of a faith journey. And so we sought to resonate with the language of the church and the messaging of the church insofar as they're working in our favor. We wanted to point out the irony of a marginalized community marginalizing our own, show the effects of social exclusion. That is, people were putting all of these boundaries around themselves and not realizing that everyone else was putting boundaries around themselves. And so pretty soon they've put baby in the corner. And no one seemed to realize that my little boundary is what's putting baby in the corner, because my little boundary compounded with everyone else's little boundaries is completely isolating. We wanted to show the varied ways in which LGBTQ people enact their identities to try to undermine stereotypes. And we wanted to show how fear of disclosure fosters a sense of dishonesty and mistrust. That is, we blame gay people and bisexual people for the consequences of the bias that they experience. And we wanted to emphasize that. This is an example of a story card. So the Acceptance Journeys campaign that we developed had multiple components, but we wanted to include a sort of narrative and interpersonal communication component, as well as a mass media component. The story cards were designed to address the interpersonal component and the narrative component. So what we did was we invited allies from the community to come in and talk about their stories of acceptance. And then our copy editor pulled from those stories passages that represented the themes that came out of our focus groups and were aligned with our recommendations. And then we built these story cards. We had probably at least 100 of them, but each of the story cards is talking about the allies' journey to acceptance. That is a moment when they moved towards acceptance, or they had an experience that made them realize how homophobia was impacting someone they loved. So, excuse me, the story card has two sides, the front and the back, and we would just leave them all over the place, on the bus, at the grocery store. We went into United Way funded agencies and conducted trainings with employees. We went into churches, we went into schools, and we used these story cards to tell people's stories. And also, and we made them sticky. They were very, very beautiful. So when you see it, you're inclined to pick it up and read it. We distributed about 2,600 story cards. We had 25 acceptance journeys presentations. We were featured in Black Nouveau, which is a public television segment in Milwaukee. We got tons of secondary coverage over them, but we also had a mass media component. The mass media component included bus ads. Oh, excuse me, I'm getting ahead of myself. We concept tested the story cards to make sure that they didn't backfire. So this is a lot of numbers. You need not interpret them all. That I just want you to see that in the columns are individual story cards, and in the rows are evaluative measures. And what we found was that the story cards by and large were acceptable. They were liked, they were easy to follow, they were pleasant, they were believable, they were realistic. 0 is the midpoint of this scale. It ranges from -3 to +3. And what you can see is, with the exception of one story card, one dimension of one story card, they were all positively received, and those positive evaluations were significantly above 0. So as long as a story card passed this muster, it was introduced to the world. We also had our mass media components. We had bus ads, billboards, train stations, newspapers, airport, and we focused on the airport because it is a large employer of the Black community in Milwaukee. Each of the ads had our branding, had a tagline, and had an image of an ally who's from Milwaukee and their LGBTQ loved one. Each year, this goes back to our sort of thinking about a stages of change kind of progression. If we're doing our jobs well, in year 1, if our message is effective, we need to change it, right? The same message shouldn't be effective in year 2 because people will have moved along in their journey to acceptance. And so our logic was that we should be getting more and more and more explicit over time. As the community becomes more and more ready to hear about our messaging because of the work we're doing on the ground, we should be able to get more and more explicit without backfiring. And so that's what we did. As you can see, our taglines changed over time. So it's very vague in the beginning. And by the end, we're saying, my brother shouldn't be judged for who he loves, or my son's love, who my son loves does not change my love for him. Very explicit. You'll note, however, that and nowhere in these, in the media materials, do we use the word gay, lesbian, transgender, queer, none of the above, because through our focus groups, we came to understand that that would lead to some counter arguing. And people didn't want to be forced to have conversations with their young children that they were not yet ready to have. And if we force them to do that, we lose. So we were trying to be subtle and at the same time, very clear about what we were trying to say. This is the design of our evaluation. It was a rolling cross-sectional design where we collected survey data from the community every year for 5 years. And we also had 2 comparison communities. We oversampled the Black community so that we could be sure to do sub-analyses to ensure that we were reaching our target audience and any effects were occurring in the target audience. The comparison communities were chosen because they were matched based on demographics, segregation, poverty, Black incarceration, and other relevant measures. And just as a sidebar, at the time, these were the 3 most segregated cities in the entire country. That surprised me. After living there, I'm not that surprised, but it did surprise me. Okay. The first step to establishing effects is to establish exposure, right? You can't have effects if people don't see your ads. And so we gathered targeted impressions and total impressions, meaning how many times did eyeballs see our ads? These numbers were provided by Clear Channel. They are not overestimates. There are no mistaken commas here. We had this many impressions. They were in the millions. But the problem with impressions is that it doesn't allow us to relate that exposure back to cognitive outcomes. So in our evaluation, we also had self-report measures of exposure that we developed based on actual campaign ads. So aided recall, where we showed images of the ads and we asked people, did you see this ad? Did you see this ad? Did you see this ad? And we created an index of exposure. And over the life of the campaign, when we created new ads, we just added them to the running list of ads in our exposure measure. The thing about that, though, is that having been exposed to an acceptance journeys ad that may not be the cleanest measure of exposure, right? Because you could have seen other ads that were designed to address homophobia. At the time, there were several other campaigns going on. None of them were national, but there was one called Gay Neighbor, and there was one called, you might remember Wanda Sykes had a series of advertisements where she was saying, talking about the language that we use to talk about gay people. And the point is that there were other activities going on that could contaminate our results. And so we wanted to demonstrate that, in fact, our exposure measure is capturing what we think it's capturing. So we created an index of other non-acceptance journeys, anti-homophobia ads. And we said, okay, presumably if our exposure measure is capturing exposure in Wisconsin, we should see more exposure to the acceptance journeys ads in Milwaukee relative to the comparison cities. And that's what we see. When we look at the non-acceptance journeys ads, we see no significant differences across cities in exposure to those ads. And the primary mode of exposure, channel of exposure for the non-acceptance journeys ads was through the internet. When we look at just acceptance journeys ads, Milwaukee was dramatically more likely to have, Milwaukee residents were more likely to have been exposed to the acceptance journeys ads, and the primary channel of exposure was through billboards, which is consistent with our advertisement placement. When this map represents the placement of our first round of ads, and what I want you to notice is that we have strategically placed our ads in the Black community. That is, the darker areas of shading represent more a higher proportion of Black residents. And so we put our ads on the way in, throughout, and on the way out of that neighborhood. And then When we look just within Milwaukee residents, we see that Black respondents are more likely to have been exposed to the acceptance journeys ads by far. 45% of our respondents within Milwaukee reported exposure to acceptance journeys. Only 16% of white respondents in Milwaukee reported exposure to acceptance journeys ads. So we're feeling pretty good about that we're reaching the audience that we intend to be reaching with a measure that's capturing what we think it's measuring. And we found significant relationships between exposure to the acceptance journeys campaign and acceptance of gay men. And that relationship was mediated through perceptions of the impact of stigma on the lives of gay men, by perceptions of community acceptance, and by attitudes towards gay men. Stereotype endorsement was a non-significant mediation path, and I'm happy to talk. I have some thoughts about why that might be the case. I was delighted, however, to find these effects. To be honest with you, I was terrified, but at the end of the day, what we have demonstrated is that we can have effects at the community level, right? And changing community-wide acceptance of gay men as a means to reduce inequities in HIV infection. And that's one strategy, that's one strategy for addressing these fundamental causes of inequities in the context of HIV. That's focused at the community level. But because these fundamental causes are so deeply woven into the social fabric, these inequities will continue to show up. For example, pre-exposure prophylaxis, this amazing, PrEP is up to 98% effective at reducing HIV infection. It works if it's taken correctly. But PrEP uptake is distributed inequitably. I mentioned earlier the distribution of HIV infection in the Black community relative to our representation in the population. We are almost half of HIV infections, but only 9% of PrEP users. And this graph does not disaggregate the data by gender. The disparity is even more pronounced when we think about Black women. Only 7% of Black women who could benefit from PrEP in the United States currently have used it. This is a pretty intense inequity, right? So another way to think about this is the PrEP to need ratio. If you take the ratio of the number of new infections in the community over the number of people who are using PrEP, that gives you a sense of whether or not the amount of risk that's out there is being met by the amount of prevention. To the extent that that number is 1, we're doing a pretty good job. If it's over 1, we've got more people using PrEP than probably need it. And if it's under 1, we've got fewer people using PrEP than probably need it. The PrEP to need ratio for women is 0.4, as compared to the PrEP to need ratio to men, which is like 4. We have learned that these inequities are in part because women who are at risk for HIV don't really know that PrEP exists. So we sought to understand, like, when we tell you about it, what are the things what are the factors that shape your willingness to use it? So we surveyed 1,437 women at the DC Health and Wellness Center, which is a local family planning clinic. I should just note that Washington, DC is experiencing a localized epidemic. The rate of HIV, the prevalence of HIV in that community is 1.9. An epidemic is present when there is a community prevalence at 1%. The prevalence rate for the Black community is much higher than 1.9. So we're focused on trying to reach a community of people who could really benefit from PrEP in an HIV hotspot. So we surveyed a group of women at a family planning clinic. We asked them to complete a survey about their risk perceptions, their risk behaviors, and then the classic reasoned action stuff, attitudes, norms, efficacy, and so on. A little over a quarter of the women that we interviewed demonstrated extremely high behavioral risk for HIV infection. That is, they had 3 or more HIV behavioral risk factors that they were engaged in. That doesn't even account for partner-related risk factors. That is, a partner who is ostensibly monogamous, but not really. So we selected this subsample of women who are at very high risk for HIV because we wanted to understand what psychosocial factors go into their consideration of using PrEP when it is really relevant to them. This is something that is very relevant to them. Among the women who were at risk for HIV, all of the women in the sample were at risk for HIV. This subsample was at very high risk for HIV. Mean age was 27. They were predominantly Black, single, had graduated from high school, and had a household income of less than $25,000. For context, in Washington, D.C., rent is easily $2,000 for an apartment. Washington, D.C., $25,000 does not get you very far in Washington, D.C. So we're working within a sample that is essentially living under conditions of poverty. As we anticipated, we found low perceived risk for HIV acquisition relative to the behavioral risk. And only 12% of the sample had previously heard of PrEP. But after watching the video, 13% of the sample was interested in getting on PrEP. As you can see, one of the strongest correlations with intentions to use PrEP was having discussed PrEP with a healthcare provider in the last 12 months. So our evidence suggests that women who could really benefit from PrEP don't even know that it exists. When they learn about it, they're positive about it, they're excited about it, they're willing to use it. But healthcare providers serve as a very important gatekeeper to PrEP for women in terms of raising awareness, but also when we look at women's consideration of PrEP, they lean heavily on their provider. These norms are very important in their consideration of whether or not they're going to use PrEP. But we have found this in probably 7 data sets. Healthcare providers women rely on their healthcare providers' recommendations in deciding whether or not to use PrEP. That means healthcare providers are gatekeepers to PrEP. As a biomedical intervention, not only am I relying on my provider's advice, but I have to get my provider to actually write that prescription. But our evidence suggests that providers' willingness to discuss PrEP and provide PrEP is racially biased, even when the patient is eligible and requesting it. We recruited a sample of practicing healthcare providers who have prescription writing privileges and are practicing currently in an HIV hotspot. This was a national sample, but focused on HIV hotspots. We randomly assigned healthcare providers to receive a vignette about a patient who reported a recent STI and was asking about PrEP. We expected to find biases in clinical judgments that disfavored Black women and substance users. We thought the effects would be mediated by biased beliefs about sexual risk compensation and by biased beliefs about women's abilities to adhere. In other words, we thought providers are going to be less inclined to write scripts for Black women when racial bias is high, because they're going to think that their stereotypes of laziness and hypersexuality will be activated. They'll think women will go out and engage in all kinds of risk behaviors if they start using PrEP, and they think that we can't keep up with the regimen, that we're not going to be adherent. So we ran this experiment hoping that we would find nothing, and we found something. We found, as we expected, that there was an interaction such that providers who endorsed more racist beliefs were less inclined to write scripts for Black relative to white women because of biased beliefs about adherence. That is, providers who had higher racial bias were less likely to write scripts for Black women because they thought that we wouldn't adhere to the PrEP regimen. Not only were they less inclined to write prescriptions, they were less willing to even discuss PrEP with that patient. Our evidence suggests that this inequitable distribution of PrEP is in part due to the fact that women who are eligible for it don't know it exists, and they're relying on their healthcare providers who are not introducing it to them systematically and not writing scripts. And that's because of racial biases that are at work, even when the patient is eligible and requesting it. Healthcare providers are gatekeepers to information. They are gatekeepers to access to innovations in prevention and detection and treatment. And so there's a critical need for evidence-based interventions focused on mitigating racial bias among them. I'm short on time, so I'm just going to fly through this last couple of slides, but this is our answer to those data. We sought to mitigate bias through a universal PrEP discussion and provision. That is, we intervened at the DC Health Clinic and implemented universal discussion of PrEP and universal provision of PrEP. to women who are eligible for it. First, we train providers and clinic staff to communicate with their patients, to gain to record a sexual history, to evaluate PrEP patients for PrEP eligibility, and to prescribe and bill it. And then we implemented electronic medical record reminders to remind every provider to talk to every woman about PrEP. And then we implemented a patient education component where we looped a video about PrEP in the waiting room, so that when they got into the clinical interaction, it wasn't the first time they'd ever heard of it. The provider and staff trainings were led by a local PrEP expert, and we had a couple of booster trainings along the way. We evaluated this staged intervention using time series analysis, and the data were derived from the electronic health records of 1,720 clinical encounters. We found that we dramatically increased the proportion of women who were screened for PrEP in the post-intervention period relative to the pre-intervention period. So this 0 to 10, this is the pre-intervention period, that's our baseline. Then we implemented provider trainings, and then we implemented the electronic medical record reminders, and then we implemented patient education. And as you can see, the provider trainings alone increased PrEP screening, and to the extent that during the study period, PrEP screening was increased from 5.6% to 89.2% in the clinic. We also found similar outcomes for PrEP counseling. And you can see that these wear-off effects are then reversed by the next intervention component. Of course, this is a whole intervention, right? Like, this is not to say that you can implement this piece alone or this piece alone or this piece alone, but rather together, we demonstrate significant increases in PrEP screening and in PrEP counseling and in PrEP provision. Sorry, I'm on the wrong screen. There we go. We increased prescriptions for PrEP from 2.6% in the pre-intervention period to 8.1% in the post-intervention period. This study is one of the first of its size to do this, to try to implement this universal PrEP provision, and it is consistent with the new CDC guidelines, which recommend providers offer universal PrEP screening and PrEP counseling and PrEP provision. This structural intervention really was designed to address healthcare providers' racial biases. By introducing PrEP to everyone, we don't make any space for them to make to make fine-tuned distinctions between this patient and whether or not I should mention it and whether or not she can adhere. Instead, talk to everyone. And we moved the needle at the end of the day. We increased PrEP provision, PrEP screening, and PrEP counseling. As with inequities in HIV and risk prevention, as with inequities in HIV risk and prevention, thinking about inequitable COVID outcomes through an intersectional lens invites us to think about the social and structural factors that shape COVID risk. Although individual behaviors confer protection, communities of color will continue to bear a disproportionate burden of COVID outcomes in terms of incidence and mortality, unless we target the fundamental causes that lead to the emergence of these inequities. By addressing the fundamental causes of disparities, we can not only mitigate inequities in COVID outcomes, but we can also make progress on eliminating the seemingly intractable health inequities in numerous other health domains. Before I close out, I just want to acknowledge my collaborators and my partners. And I also must acknowledge, before you turn the camera off, my funders. Thank you for your attention. Sorry I went more than a little bit over, but I would love to take any questions that you might have.
Well, I mean, this is such important work. If you guys have any questions, you can raise your hand, or you can put your questions in the chat. And we'll have Dr. help address this. It's a really important research program Dr. Howe is working on. I just have a quick question. Like, we know that currently in COVID, I don't think there are any like racial disparities in terms of COVID vaccine uptake, right? Are you aware of, we looked at recent data, it seems like uptake rates are quite similar across racial groups. I think probably a little bit higher among white and Asian Americans, but overall across the board, it doesn't seem like a huge gap in
Right.
vaccine uptake.
Right. I
Right.
think rather in the context of COVID, the disparities that we see that are most dramatic have to do with incidence and mortality, right?
Yeah. So
We're
that's what I was gonna say, right? I mean, even though people are taking vaccines at the same rate, but still, I mean, more African Americans get sick and they get hospitalized and they put, they die from COVID. I think the rate is like recent stats I was looking at, like twice or three times as likely for hospitalization. So why do you think that might be the case? We think about
I
the
think this is
structural.
absolutely aligned with what I've been saying. I mean, as innovations emerge, in this case, maybe it's diffusing equally, but the same protective behaviors don't offer the same protection under different circumstances. It's like having a single sex partner in an HIV hotspot as compared to having a single sex partner in a non-HIV hotspot. So the vaccine confers protection, but not entirely, right? People still will get COVID, their cases may be milder and so on. But when we seek treatment, we still have to interface with a healthcare system that is systemically racist, right? So getting into appointments is problematic. The time that we spend in the appointments, the communication that we have, and the sort of shared decision-making that happens in the clinical encounter is often not even present for Black communities. I mean, in the context of HIV, Black women routinely report that their healthcare providers do not discuss their sexual health with them, even in HIV hotspots, even when they're at risk for HIV. The other thing is that we have, so the social circumstances are such that people who are in service roles, for example, are much more likely to be people of color. And so the risk exposure is higher, disparately higher, right? And we're working in closer quarters. We also tend to live in closer quarters and in multi-generational housing situations where, for example, a parent might live in the home. We know that communities of color are more likely to live under circumstances like that. And so I think the social and structural circumstances are what feeds these inequities. So the vaccine is very important, but even if it's equitably distributed, we will still see disparities in risk exposure and in mortality. Because the other thing is the care that we receive isn't as good, frankly. I mean, there's a mountain of evidence that shows Black people are mistreated in the medical system in terms of treatment, in terms of medication, provision, and in terms of quality of care in the clinical interaction.
Yeah, well, you guys feel free to chime in or raise your hand if you have questions.
But actually, Dr. Nan, I just want to come back to that because I think it's not hopeless, right? Like, we are communication scholars. Like, this is what we do. Like, we're ready for this. We are ready.
You know what? I do feel powerless. Like, as a communication researcher, like when we really look into the causes, for disparities, everything, it's really structural. I just don't feel like communication is well equipped to deal with that kind of challenges. Perhaps you're here today to enlighten us what we can do. Right.
Well, yeah. I mean, I think one example is this work that we're doing in the clinic. Healthcare providers are, they went into that profession to care for others, right? Like, so I think that I am inclined to take a step back and say, okay, under these circumstances, what can we do, right? And so to the extent that we can remove the kinds of judgments that are affected by biases in clinical judgment, we can start to undermine those processes. And at the same time, we can be offering providers trainings about identifying their biases and mitigating them in practice and in real time. And at the same time, we can be building structures, communication structures, that undermine completely that process of bias. So like the electronic health records, that takes it out of the provider's hands to decide whether or not he should talk to anyone about PrEP. He should just talk to, or she should just talk to everyone, right? And it's not just the EHR reminder, it's the training that we offered in conjunction with that reminder. So we're giving providers the tools, and we're to engage in quality shared decision-making with their patients. And then we're also making it mandatory that they do so, right? And so I think that there are things we can do. And those things will vary depending on what it is that you're studying. But I think that as communication, because communication is so central to everything, that we can certainly use the tools that we've been equipped with to try to undermine some of these biases, not just racial biases, but also classism, heterosexism, ableism. And this is a moment in history where people are listening. I could never have gotten my article published 10 years ago. The article that you invited me to submit, I was delighted by the invitation, but I have tried to say some of these things through other venues over the last 15 years with no success. This is a moment in history that people are listening, and people want to affect change, and they're feeling kind of helpless. And so I think we are uniquely prepared for this moment in history.
Wow. I mean, with these powerful messages, I can't think of a better way to end this talk with these really inspiring call for actions, sort of, from you. We do have a quick question from Ali. If people are willing to stick around, maybe we can address this one quick question. Ali asked about your health ad intervention in Milwaukee, and she asked, are the ad content narratives or call to action messages?
Fantastic question. Thank you very much. I think they changed over time. So their purpose changed over time. So early in the campaign, it was neither. Early in the campaign, we were building credibility. And so we wanted to get people thinking and paying attention. So that's why our first message was a question. And that's why it includes the word you. We know that in advertising, when you are speaking to, when you ask someone a question and you make it didactic, like, what do you think? That we can enhance the likelihood that people will elaborate on our message content. And so we, early in the campaign, we were really just trying to generate brand recognition, goodwill, and credibility in the community, so that later, when we have messages like whose life, or who my son loves doesn't change my love for him, this sort of role model message. I wouldn't call it narrative, but it's a role model. It's an exemplar. People will be receiving of that message because we've laid this foundation and built this credibility, right? So the function of the message sort of changed over the life of the campaign, and depending on what we were hearing in the focus groups. But by and large, it was one of those two functions. It was either increasing credibility, raising brand awareness, and building ourselves the opportunity to say more controversial things later without backfiring. And then the later messaging was very much exemplification.
Okay. Wow. I mean, this is wonderful. This is great. Thank you so much, Dr. Shawnika Howell, for coming today and giving this wonderful talk. And thanks to everyone for sticking around.